Good afternoon, everyone. My name is Shannon Kupka, and I'm a project manager working with the nursing home teams in New Mexico from Health Insight. I'd like to welcome you to our half-hour Hot Topics series. These webinars are designed to provide you with great ideas on antipsychotic reduction strategies in a 30-minute time frame to accommodate your busy schedules. They're brought to you by the New Mexico Statewide Partnership to Improve Dementia Care Work Group and sponsored by the New Mexico Department of Health, New Mexico Healthcare Association, and Health Insight. We're very excited about today's presenter. Julie Foster graduated from George Mason University with a BSN in 2007. As a nurse, she worked on an inpatient cardiac unit and then as a clinical research coordinator for a trauma infectious disease study in Landstuhl, Germany. She graduated from Georgetown University with an MSN as a family nurse practitioner in 2015. Since then, she has worked for Southwest Center on Aging, which is a geriatric practice in Las Cruces, New Mexico. Now, Julie is currently working with Mesilla Valley Hospice, doing palliative and hospice care as well. I will now turn things over to Julie Foster.
All right, excellent. And I do tend to move around when I'm talking, so if you can't hear, just put it in the chat and then Shannon can tell me. So you can go ahead and advance the slide. So I'm gonna jump right in because I know that you guys don't have a whole lot of time. When I first started putting together this presentation, kind of thinking about behaviors and thinking about dementia, one of the barriers that I kind of ran into trying to get evidence-based research and evidence-based suggestions for you guys is that, you know, we tend to throw around behaviors and sundowning pretty loosely, at least in the ALFs and in the skilled nursing and just when talking about dementia patients. And when looking at the research, even amongst researchers, it's really poorly understood. It's a poorly understood phenomenon. There's not a lot of good research out there, partially because we don't even have a consensus amongst researchers of what sundowning actually is. But for our purposes, I think we need to come up with at least some sort of working definition. So we're going to use the definition of sundowning and sort of behaviors is this emergent or worsening of neuropsychiatric symptoms in the late afternoon or early evening, and that's more referring specifically to sundowning. Behaviors in general, I think when we refer to behaviors, I think most of the time we're kind of looking at anxiety, agitation, aggressive combativeness, pacing, wandering, sometimes it's resistance with ADLs, screaming, yelling, and then sometimes, depending on the type of dementia, you will see visual or auditory hallucinations. Okay, next slide. So some of the causes, things that we need to keep in the back of our mind, for one thing, is causes of behaviors. Is this something that we can fix? Is it something that we can treat and then take away those behaviors? So always kind of keep in the back of your mind that, you know, I think most of you who have been doing this for a while, you start to see a patient who didn't typically have any kind of behaviors. And the first thing we think is UTI, which is good because we do need to rule that out. That's something that we can actually treat and fix. So other clinical conditions, this can be any kind of infection. I mean, sometimes it's pneumonia, sometimes it can just be virus. Think about yourself in the sense of when we don't feel good, when we don't feel well, we're not exactly the most patient. We might actually get irritable. Dementia patients are still the same, so they actually get like that too. You know, other clinical conditions to sort of keep in the back of your mind is dehydration, pain, which we're going to talk about today. Hypoxia, so if they're a COPD patient, if they're an asthma patient, if they're a stroke patient and they have low oxygen that goes down, that obviously exacerbates some of those behaviors. Constipation is another big one that sometimes I think we don't actually think about, but if you're uncomfortable and you don't feel well, then again, you can start to see the emergence of some of those behaviors. Drug-induced. So if you start to see someone starting to act differently, sometimes we do this to them with the medications that we give them. Always kind of keep in the back of your mind, did we just start something? Or even if they've been on it for a while, you know, especially with dementia patients and the elderly, we give them oxybutynin for overactive bladder and for the urinary incontinence. This is an anticholinergic. It's one that we know can worsen agitation and worsen confusion, especially in this population. Diphenhydramine. Benadryl. This is a medication that, especially when working with geriatrics, I never ever prescribe unless it is specifically for an acute allergy, acute allergic reaction, not just seasonal allergies, but diphenhydramine. I never ever use it for sleep. I never ever use it for agitation. I really try and steer clear because it does tend to make that agitation and the confusion worse, not to mention that like increases the falls risk. Benzodiazepines are another one. If you've been working with dementia patients, I'm sure you've kind of witnessed it, at least with some patients, is that it has that paradoxical effect. Instead of making them calm, making them relaxed, it actually ramps them up. And part of that is because it lowers the inhibitions and it can make them just make that agitation worse. And then there's the psychological and the environmental factors with the elderly, and then specifically with dementia patients. Always kind of thinking, is this behavior because they're lonely? I mean, there's still people there, if they're on a memory care unit, they're with the same people all day long, they're stuck there, they have a complete lack of control. Even though they have dementia, they still have basic feelings too. So loneliness, frustration, they can't communicate their needs the way that we do. Unfamiliarity with the setting or the other people, especially if they're new to transition onto that unit or they've been out to the hospital and had to come back. Discomfort. So just have they been in the position too long? Have they been sitting in a recliner? Have they been sitting in their chair for a long time and they're just uncomfortable? Disrupted routine or schedule. Obviously with dementia patients, super important to kind of keep them on the same schedule and routine. Any deviation from that can then set off some of those behaviors. Inappropriate lighting, sensory deficits, their hearing, their vision isn't as great as it used to be. That right there alone can make them more confused, can make them a little bit anxious. And then noise. Is it noisy? Is it loud? Is there someone on the unit playing music for, actually for their benefit, but is that just ramping everyone up? Is it ramping them up? All right, next slide. But we're talking about pain today specifically. So pain is often, this is something that they have found in research, pain is often expressed through behavioral disturbances and is thought to be one of the most important causal factors of behaviors and sundowning in dementia patients. So all those other things aside that can cause those behaviors, pain is often at least a portion of it. The next slide. And just some things to kind of consider when thinking about dementia and pain. People with dementia may be disproportionately affected by pain than those without cognitive impairment. The prevalence of chronic pain is strongly related to age, so over 72% of those above the age of 85, which you gotta think, specifically osteoarthritis, very, very common. These joints have been moving for 80 or 90 years. It is very likely that they have some discomfort. Evidence suggests that up to 50% of those people with dementia regularly experience pain, and most likely it is probably not optimally treated. Preliminary evidence suggests that those with Alzheimer's disease have alterations in their cortical and emotional perception of pain, processing, and behavioral responses to pain. So add on top of the fact that we don't understand Alzheimer's disease, we don't understand dementia that great really at all. There's varying theories out there of what causes it. Chronic pain as a syndrome, chronic pain is a poorly understood phenomenon on top of that. So when we're trying to deal with pain with people with dementia, we have a lot of barriers, we have a lot of challenges because both phenomenons are very poorly understood. So it makes this a very challenging thing. And then also there's over 35 different pain assessment tools for older people with dementia. So I don't know, and you guys can answer in the chat, and maybe we can actually address it later. But what kind of pain assessment tools do you use? With someone with mild dementia, maybe just that 0 to 10 is that's an appropriate, or they can actually answer that question. But as you get into the moderate and more severe, more end stage dementia, obviously that is not going to be the most reliable or most accurate tool to use. So I was just kind of curious if you guys have any tools that you normally use for these patients that you're using in your facilities. Next slide. And then some of the things that we were just kind of talking about, but I think this is things that you guys run into every single day and are probably pretty familiar with, but barriers for pain management in patients with dementia. Just obviously what I was just saying, the cognitive impairment and the communication makes self-reporting difficult. So, we're always told to treat pain that the patient says they have, but if they can't report it, we're going to have some other tools. Elderly patients, so especially in geriatrics, they don't want to complain. So, I mean, sometimes you have the one-off or you have the patient that they want to complain about everything. But for a lot of these people, they don't want to go. They don't want to come tell you that they hurt. There's a lack of consistent evidence-based pain assessment tools for those with dementia. Lack of education for us as caregivers and providers. They might not come tell you that they're in pain because they don't. And then also they don't want to be put on those narcotics. They don't want to get hooked. So they're not going to come and tell you. The liability associated with opioid medication. So more and more as providers, we're just getting beat down for giving pain medication, especially to elderly patients, because of the fact that it obviously makes them more at risk for falls. It makes them more at risk for cardiovascular or cerebral vascular events. More and more providers are not wanting to give pain medications to this population. They don't want to deal with it. They don't want to deal with the liability. And it's not that they don't care, but they mainly don't want to deal with the liability and then all the hoops that we have to jump through, all the regulations, like getting that pain contract in place, getting a urine drug screen, and then checking the PMP. We have to do all that once we start a narcotic. And so more and more providers are patients, they're saying, I'm not dealing with the pain. Go see pain management and go see pain management specialists. But obviously you guys know, if you're working with dementia patients, how realistic is it to send somebody with moderate to severe dementia to the pain clinic on a regular basis? As it gets more difficult for them to walk around, as it gets more difficult, like as their cognition goes, that becomes a huge stress to both the caregiver and the patient. It's taking them out of their environment as well. So this is a problem, and it's something that they're working on coming up with better guidelines, but there's very poor guidelines specifically for opioid management of patients with dementia. And then just all the adverse and side effects of the pain medication. Most of these patients are already high fall risk. Most of them already battle constipation. They usually do have some sort of cardiovascular condition. So kind of balancing that risk benefit is very, very difficult when coming up with how we're gonna treat the pain. Next slide. So when medications are actually indicated. So obviously I think infection's a huge one. We kind of talked about if they have, they're starting to have behaviors and we think they really do have a urinary tract infection, that warrants, treating. If they're harm to self or others, I think this can be a totally separate conversation, but I know we're getting hit with antipsychotic use in facilities. And when it's appropriate to use and when it's not, I think you can always make the argument that if they truly are distressed, if they truly are a harm to themselves or others, that is when we do need to initiate some sort of probably pharmacotherapy, not just the behavioral and environmental modifications. And then pain. And next slide. So subjective versus objective pain signs. So subjective being sort of what we see, what the patient tells you, something that's not necessarily something you can specifically measure. But always some things to kind of be looking out for especially with patients with dementia. It's what the patient tells you, but grimacing, moaning, resisting help with activities of daily living, especially the patients that were never really a problem and all of a sudden they're pushing you away. They don't want you to change their brief, they don't want the bath, irritability, crying, yelling out. All of these are just what we would consider subjective pain signs. The next slide. These are super important. They give it's something you can actually measure. It's something you can go back to the provider with. And so it's elevated heart rate, elevated blood pressure, dilated pupils, diaphoresis or sweating, and which is kind of iffy, I think, sometimes with the elderly, because geriatrics don't sweat the way I think, you know, younger patients do, but it is still there. Peripheral vasoconstriction is another hard thing. There's so many conditions with geriatrics that can cause that vasoconstriction, but it is a pain sign. Nausea, which is subjective, but you can see if someone's nauseated. Vomiting, diarrhea, or changes in their appetite, how much they're taking in. Has their appetite been diminished? They were always really good at eating and all of a sudden they're not, but you can actually give a measurable, they were eating 100%, now they're eating 50%. And then next slide. And then there are these kind of gray areas, subjectively objective. So positional, these are the patients that if you're looking at them, and you see them on their unit and they're all of a sudden limping or leaning to one side, or you see them, what sometimes we think is just agitation is them repositioning themselves, or when they lie on the floor, sometimes that is actually giving them relief and that's why they're doing it. Sitting on the edge of the chair. You can also see some hypertrophy of the unaffected sides. So if they start to compensate long enough, you actually start to see atrophy on one of the sides. So their muscles getting weaker, and that extremity, especially it's on the extremities, might get thinner. And the other side is actually getting bulkier because they're really compensating. You can even see facial creases. If they're grimacing long enough for a long enough amount of time, you can actually end up seeing facial creases on one side. Sensory avoidance. I think this is a big one sometimes that we see, and we don't always necessarily think of pain as being the cause, but they avoid noise. They don't want to be touched. They don't want to eat or drink. They're taking off their clothes. They're speaking slower or softly. And I think about this sort of like if you've ever had a migraine or you've seen someone with a migraine, think about what they do. They don't want bright lights. They don't want a lot of noise. They just want to be quiet, and they want everyone else around them to be quiet. They're not hungry. So kind of think of that same thing with dementia patients. If you start to see them doing some of these things, think it could be pain. And then distraction techniques. I think this is another one. The teeth, the clenching their fists, the ones that will bang their head up against the wall. Sometimes that can actually be, it's something to distract them from the pain. And we almost do it instinctively. Think about when you, like if you stub your toe and you go and you hit your leg, it's kind of the same thing. So if you ever see them kind of grabbing their own, like when they do that, when they grab their own arms and they hold on real tight, sometimes that can actually be a pain sign. Next slide. So I don't know, I think I'd already asked like what kind of tools you guys use. This is just one of using it. It's nice because it still uses the 0 to 10 scale, but it's a more of a functional pain assessment. And really, really important is where we're moving with pain management just in general is looking at not just what the patient's telling us, like, oh, it's like a 0 or it's a 2, but looking at what has functionally changed with them. This is always a great report that you can give to the provider. They really should be documenting it, especially if we're going to start medication. So looking at functionally, this patient used to ambulate to the dining room, but is no longer ambulating because of pain. This patient used to sleep all night long, but they're waking up because they're in pain. They used to eat 100% of their meals, but now they're only eating 50. They used to be able to put their clothes on, at least help with, grooming or help with dressing. Now they are no longer doing it. So it kind of gives us something objective, but something functional, because it's actually affecting their quality of life. It's affecting their sleep. It's affecting their appetite. It's affecting, their ability to ambulate and their mobility. So those things are huge to keep in mind and to report, especially if you're looking to advocate for your resident, for your patient, to actually get medication started. This is huge because it really helps the provider. It really paints a picture for them, and it explains why we're actually starting medication. So again, back to those risks, kind of the risk benefit. If this is affecting this person's quality of life, this is huge. So very important. Next slide. So vital signs. I know we take them all the time. We do this constantly, but this is so important. It goes back to those objective pain signs. I know some people will argue that chronic pain patients don't have changes in vitals. That's actually not true. But I think the really big thing is to do every single one of them. Temperature, even a low-grade temperature, can be extremely important, especially with the elderly, because they're not going to spike temps the way younger patients do. So even a 99 is important. And then always, always, always looking at their baseline. If their heart rate was always in the 50s and now all of a sudden it's in the 90s, start to think about why it's changing. Is this a sign of pain? Was their blood pressure always low before? Now it's higher. Is that a sign of pain? Respiratory rate is huge. I know a lot of times we're really tempted just to write, it's 16, it's 18, they're fine. But actually count it, because sometimes that can be the very first thing before anything else changes. That fast breathing can be a sign that they're in distress. Next slide. There you go. I think you guys are probably all familiar with a lot of this, and I'm going to go pretty quickly over this, but it's just non-pharmacologic interventions. So things that you can utilize instead of going to pain medication first, distraction, positional changes, activity modifications, and just different sensory techniques. You can go to the next slide, because I know we're kind of running out of time. I'll pick up the pace. Pharmacologic intervention. So acetaminophen, still, even if they have liver disease, always a good first choice, always, because it's relatively benign, doesn't affect their cognition. NSAIDs like Advil, Motrin, good, they can help with inflammatory pain, but always be careful when suggesting it for your patients, because it can increase the risk of bleeding, and it can be very difficult on their stomach. And then those that have renal issues, it's difficult. We should not be using it with renal patients. Gabapentin, really good for neuropathic pain and the chronic pain syndromes. Topical medications works for some people. Sometimes just that act of massaging and just that physical touch and that actual, just that care and that attention, sometimes that alone will do wonders for them. SNRIs, so a lot of times it's duloxetine. It's a great additional therapy because a lot of them end up having dementia, so it can kind of treat both. And then opioids. We try not to use them as first line. Tried all these other things, and there's no other alternative. Next slide. So this was just kind of the limitations, and I think the said that was asking if the slides will be posted, and I think they will. But acetaminophen, obviously we have to use caution with liver disease, the NSAIDs, just because of the renal impairment, especially with the elderly. Gabapentin can really cause sedation, can increase the fall risk. And then opioids, I think we know most of the risks involved with that. So next slide. And this is just some geriatric considerations just for you to think about of why it's difficult to treat the pain, and things to think about before you sort of push medication or advocate for medication, just to keep in the back of your mind. We don't have to spend a long time on this one. We can actually go to the next one. And then presenting your patients. So super important, if you're advocating and you really believe that you're starting to see some of these subjective, these objective signs that this patient really is in pain, you've tried some of the Tylenol and some of the other, non-pharmacologic interventions, they're still very uncomfortable, and you are advocating to the provider to really get them on a pain management regimen. There's certain things I think you can do to kind of present it that will really raise that alarm. This person needs to be treated, and this really is indicated to start some medication. So always think functional. What is being affected? Their sleep, their mood, their ability to ambulate, their eating. Are they not participating in social activities anymore when they used to? How are they interacting with their peers or with staff? Because if it's not interfering with these functional abilities and they're having behaviors, consider other non-pain related causes, and then try some environmental and behavioral interventions then. Are they complaining? What are they complaining of? Is it sharp? Is it dull? Is it in a certain location? Have they had it for hours, weeks? Is it chronic pain that all of a sudden is starting to get worse? What are we currently doing? List everything, tell them everything you've already tried so they don't just come back with saying, oh, just try some redirection and some Tylenol. Like, let them know, I've already tried this. I've already tried activity modification. I've already tried repositioning. We've already done distraction. We have aromatherapy going on the unit. And then the pharmacologic interventions. No, going in, especially if you want to advocate to a doc, to an NP to start these, what have you been using? How often? How much? Do they have a PRN? I can't tell you, unfortunately, how many times I go in and I hear that this person is still in uncontrolled pain and they have this PRN medication that's never been used. And so it's hard because that's how we kind of adjust the medication that's already on board, is a lot by how often you guys are having to use the PRN medication. So really good thing always to know before you're going in to kind of advocate for a change in the plan or increased medication. Always know what they're taking, how often, if they have PRNs, and if they do, how often are they having to take it. So next slide. And then how is the current plan not working? So yes, I've given this medication, but they're still not ambulating, or they're still waking up in the middle of the night complaining of pain, and I have, I've done the PRN, I've done this. Or if the current medication is working, but it's not lasting, how long does it help? If you know the history, this is always a good one to include, but has the patient tried other medications? Especially if the provider is someone that's very difficult to get a hold of, then definitely know if they've already tried, naproxen, Tylenol, hydrocodone in the past, and it didn't work, then know that so that you can tell them that then, so they don't just throw a med and then kind of move on. Any allergies, and if you know what happens, there's a lot of patients who write down that morphine and codeine are allergies because it made them nauseous or because it made them itch. Not true allergies. I get the fact that we can't always change it in the system because they've reported it as an allergy, but it really, really helps if if the family has said, oh no, they just got a little nauseated with that. That helps immensely because it doesn't take a whole bunch of medications out of the possibilities to treat them. And then also, are there any other signs or symptoms going on? Is there fever, nausea, vomiting, diarrhea, swelling, redness, temperature changes, paralysis, cough, all of these other things that could point to something that maybe is a little bit more acute, something that we could actually treat, maybe infectious cause. All right, next slide. I think I went over. I'm sorry. So any questions?
Okay, so think for a minute if you have any questions for Julie. I wanted to just do a couple of things while folks are formulating them. We do have a couple of questions or a couple of comments in chat, and there were some folks that mentioned that they're now using the Pain AD tool.
That's a good one. That's a really good one.
Good, okay.
Good.
I don't know. We didn't get any barriers in here mentioned, but if anybody would like to comment on that in chat as well, that's why we have Julie here. So please ask away. What kind of questions do you have?
And sorry, I know I kind of ran through those last ones pretty quick. Sorry.
No, they were great. Let's see, Naomi mentioned she's with the New Mexico Ombudsman Program and said, thank you very much. It's been very informative. We did have a request for the actual slides. What we usually do is to post the webinar onto our website, because sometimes the slides kind of in and of themselves are a little less helpful than having the whole content together. So they should be on our website in a couple of weeks. Let's see, Washington, you do have access to the website. What I just put in our chat up a couple of comments was the Health Insight website and the link to our half-hour Hot Topics series. So not only will you have access to this particular presentation, but you're welcome to go back and look at anything else that you know, is on there. That's why we do this, is to make it available, and you know, so you can use it for in-services and other training and whatnot. So do we have a website address? Let's see, I will copy and paste that in one more time. Let's see, Skitch mentioned, while I'm pasting that in, a barrier he's experienced is the family or a surrogate medical decision maker who doesn't want to get the patient addicted. Can you comment on that?
Oh gosh, it's absolutely a huge one. And a lot of it, I think, is it's just education. It's knowing that initially, maybe at first they're not going to want to treat, and just really, what I have found to be helpful is to just kind of let them vent, let them say what they need to say, listen, come up with a whole bunch of other usually it's the opioids that they don't want to get them addicted to. So try to come up with other things like gabapentin, like the topicals, all these other things, and then really great documentation from the caregivers is huge. When the caregivers are coming back, the people who are with their loved one all day long and saying, look, this isn't working, they are still not doing X, Y, and Z, and giving them some education on the medication, like on the opioids and how we're going to dose it, and really making them feel like they are part of the plan seems to go a very, very, very long way. Because most of them, even though they're worried about addiction, they don't want to see their loved one in pain. And if they really feel like they are also part of this plan and they're in control of when it started, how often it's given, you know, they want to know all of those things. If they feel like they're part of the plan, most of them, I will say most times out of not, they will get on board because they don't want their loved one to be in pain or suffering either. So.
Okay, thanks, Julie. One more comment, which was Skitch mentions he was at a Tufts presentation where pain was discussed as becoming a new vital sign.
Yeah.
Is this a movement?
Yes. Yes, I think Jaco is the one who did that lovely thing way back. It was years ago, but yes, like pain being the other vital sign, which is great. I think it puts it in the forefront that we need to always be assessing for it. On the other hand, unfortunately, this is what I think has gotten us into the crisis that we are now, is that because it's considered a vital sign and people have the right to get treatment, they come in thinking that they have the right to get opioid management. And so providers are kind of left in this game of, yes, I have to treat it because they told me that they had pain. On the other hand, the liability involved of getting someone addicted, or all the risks in, like the risks and the side effects of the medication, it puts us at, it's a very difficult spot. So yes, it is, but it is something, I think it's good in the sense that it puts it on the forefront that we need to be assessing for it specifically. So.
Great. Okay, I'm going to give everybody another 10 seconds to put in any final comments or questions before I release you back to your day. As I'm giving you that moment, I'm just reminding those of you in the New Mexico area or who work with New Mexico buildings to make sure that I have your name and email address. You could do that in chat, or you can email me afterward. You should have my information. The presentation will be posted to our website in a few weeks. And again, I encourage you to check out all of our posted webinars there on our nursing home library. The link was put in chat. Please share with any of your colleagues who couldn't make it, or again, use it to in-service your staff. So we will take, let's see, Jessica that says, thank you for a great presentation. Robin, tell me what state you're from, and we will have your lead send out. Oregon. Okay, great. I'll have Leah send out a certificate for you. So great, Bonnie as well. So we'll make sure that Leah gets this information. Skitch also mentioned that the opioid epidemic is causing a chronic pain epidemic. So very, very much in line with what you're saying.
Exactly. Yes, exactly. And Jessica, she had mentioned earlier, I can't pronounce it, about such a great comment about the fact that the gap for the middle stages of dementia, who aren't really appropriate for some of those tools for advanced dementia, but who really can't accurately report their pain, I'm gonna have to look up because I'm really interested to see if there is one specifically for that segment. So I think that's like a really great point. You know, it's such a range, and a lot of times some of the tools are meant for the very, very, very advanced, but that middle stage kind of gets left out. So I'm gonna have to look that up.
With that, I will say thank you once again to our presenter, Julie Foster, that you gave us such great information, and we really appreciate it. And thank you to all of you for joining us for Hot Topics. I hope you have a wonderful weekend and look forward to seeing you at our next event.